Welcome all to the our maternal medicine module, and we have the today's talk for the discussion pregnancy and spinal cord injury. Very important talk article from the examination point of view. Okay, so if there is a spinal cord injury, so pregnancy versus spinal cord injury related problems, then lesions above the T6, there is a risk of autonomic dysreflexia. So please keep in mind when the lesion is above the level of the T6, there is a risk of autonomic dysreflexia. Okay, labor diagnosis is difficult if the lesion is above the level of the T10. So you should know at what level the injury is and what is the effect. Okay, what happens above the level of the T6? What happens above the level of the T10? Above the level of the T6, there is a risk of autonomic dysreflexia. Above the level of the T10, the labor diagnosis is difficult. Okay, vaginal delivery is preferred in these patients. Early epidural will prevent the autonomic dysreflexia in these patients, and this autonomic dysreflexia is a life-threatening emergency. Okay, so this spinal cord injury that will lead to the motor, sensory, and autonomic dysfunction. See, this is classified as per the level of the lesion. Okay, it may be T6, it may be T10, it may be T12, etc. etc. It depends upon at what level the lesion is. It may be complete or it may be incomplete also. Okay, so these are the points which you should keep in mind. Above the level of the T6, there is a risk of autonomic dysreflexia, bradycardia, hypotension, respiratory compromise. Above the T10, there is no perception of the labor pain, altered fetal movement. Below the level of the T10, normal labor pain perception is there. Okay, because T10 is the level of the umbilicus. Okay, so if it is below the level of the T10, then normal labor pain perception is there. Okay. So this figure you should remember, this is from the TOG only. So above the level of the T6, risk of autonomic dysreflexia in labor. Okay. Above the level of the T10, late preterm labor and UTI. This is the SBA. Okay. Sometimes they give you the UTI and they'll ask the lesion is at the level of the T10, which is the likely risk in these particular patients, and they can give you the option as a UTI. So there is a risk of late preterm labor and UTI. Above the level of the T12, there is an increased risk of malpresentation at term, and above L2 to L4, scar tissue in the epidural space can cause inadequate epidural analgesia. So lower down, the problem is that of the epidural analgesia. Autonomic dysreflexia, T6, T10, remember T, it comes late preterm and UTI. So T, malpresentation in 12. Okay, so T12 associated with malpresentation. So these are the things which you should remember. And if there is a lesion above the level of the T4, there is a ventilation assessment in pregnancy is advised. So what is required if there is a lesion above the level of the T4, ventilation assessment in the pregnancy is advised. Then above T6, low baseline blood pressure, rise of 20 to 40 millimeters of mercury is diagnostic of autonomic dysreflexia. We have seen at T6, autonomic dysreflexia, and above T10, altered perception of the fetal movement and unable to feel labor pains. Okay, so apart from that, at all levels, there is an increased risk of anemia. There is an increased risk of pressure ulcers, a requirement for adequate analgesia for operative delivery and perineal repair, a VT score of 1 or for immobility for wheelchair users. Okay, so these are the things which we should keep in mind. Then what are the pregnancy risk in these patients? So respiratory, there is a hypoxia, there is a decreased cough reflex, there are chances of pneumonia. This is seen in lesion above the level of the T6. Then cardiovascular, there are chances of bradycardia, hypotension associated with autonomic dysreflexia. Renal, there are increased chances of UTI, calculi. Bowel, there is a constipation, and this constipation can trigger autonomic dysreflexia. Okay. Skin, there are chances of pressure ulcers. Hematology, normocytic anemia. Thrombosis, there is increased risk, especially for 6 months post injury. And endocrine, there is increased GDM risk, and psychological mood disorders are known to happen. Okay. Then coming to the preconception and booking care, preconception, planned pregnancy after rehabilitation. It is very important that these patients should be rehabilitated first before planning the pregnancy. Okay, we need to counsel regarding one, parenting challenge, and second, mobility issues. Okay, reassure that there is no increased congenital anomalies or the stillbirth. So There is no as such because of the spinal cord injury. Congenital anomalies will not going to increase or chances of stillbirth are not there. At booking visit, there has to be multidisciplinary team involvement. Then baseline blood pressure and pulse is going to be very, very important because that will differentiate it from autonomic dysreflexia. Okay. And decide the place and mode of delivery. Consider pelvimetry if there is a pelvic trauma or early spinal cord injury. Okay. Coming to the antenatal care. Again, it is always a MDT care or multidisciplinary team care. There, consider the late third trimester admission for these patients. This we have already discussed, but we'll revise it once again. Above the level of the T4, respiratory compromise, so antenatal ventilation assessment is required. Above the level of the T6, high risk of autonomic dysreflexia in labor. There is a generally hypotension, there is bradycardia and low baseline BP, which increases by 20 to 40 millimeters of mercury. That will indicate autonomic dysreflexia. So generally there is a low baseline BP, but if there is a 20 to 40 millimeters of increase in the blood pressure, that will denote the autonomic dysreflexia. Then above the level of the T10, there is a decreased pressure of the fetal movements and labor pain. Late recognition of the preterm labor is noted. Above T12, there is an increased risk of malpresentation, breech transfers. Okay. Above L2 to L4, epidural analgesia may be inadequate. There is decreased perception of the fetal movement occurs above the T10 level, and malpresentation increase breach or transfers, especially about T12. UTI is very common. Pressure source can happen due to immobility. Constipation can trigger autonomic dysreflexia. And in general, for all patients, there is an increased risk for anemia, pressure source, VT risk, need adequate analgesia either in the labor or for the perineal tear repair. Okay, so this is what we have seen basically up till now. Okay, same thing we have discussed. Then coming to the definition, exaggerated sympathetic response below the lesion, that is when the lesion is above the level of the T6 or at the level of the T6, there is an exaggerated sympathetic response. Pathophysiology is noxious stimulus which causes uncontrolled sympathetic discharge that leads to the severe hypertension, reflex vehicle response leading to the bradycardia. Okay. So what are the triggers? There may be trigger from the urinary system such as distended bladder, catheter issues, urinary tract infection. From GIT, there may be constipation, impaction that can be trigger for this autonomic dysreflexia. Pressure source can be the source for the autonomic dysreflexia, and from obstetric factors like labor, vaginal examination, etc., can trigger the AD. Okay. Then clinical features, there will be headache, anxiety, tingling in the scalp, malaise, and signs will be there is increase in the blood pressure more than 20 to 40 millimeters of mercury above the baseline. There will be bradycardia, sweating, flushing, fetal bradycardia, etc. And what complications can happen in this patient? There can be intracranial hemorrhage, stroke, maternal death, fetal distress, etc. Then coming to the management of autonomic dysreflexia, you need to remove the trigger first, empty the bladder, treat the cause, position should be upright, and use the antihypertensive. Now, which drugs are to be used? Nifedipine sublingually can be given. If it is a tablet, then that can be chewed. Then GTN spray or patch can be used. IV labetalol can be used. And another is a hydralazine. Okay, so blood pressure more than 120 by 80 may be abnormal in a tetraplegic patient. Okay, remember, generally the blood pressure is low. So if the 120 by 80 may be a sign of autonomic dysreflexia also. Okay, so the pharmacological treatment of autonomic dysreflexia in pregnancy are nifedipine used in sublingual capsules, or if it is a tablet, bite and swallow. The dose is 10 milligram to 40 milligram. So 10 milligram every 15 minutes you have to give. GTN may be applied in a patch or spray. 2 to 3 puffs can be given. Nitroglycerin 2% ointment. 1 inch of the ointment is to be applied. Okay, above the level of the lesion it needs to be applied. IV labetalol 20 to 40 milligram IV can be given. Hydrazine 50 to 100 milligram over 20 minutes. Okay, and nitropicide alone is inadequate unless used together with the epidural. Okay, so medical management of the spasms in these patients, baclofen tablets or intrathecal baclofen pump, then oxybutynin for bladder spasms, diazepam, Clonidine and tizanidine, they are not recommended in the pregnancy. So this treatment also you should remember from SBA point of view. What is used for the blood spasm? For bladder spasm, baclofen tablets or intrathecal baclofen pump can be used. Oxybutynin for bladder spasm can be used. Okay, so these are the medications which are used in this patient. Then thromboprophylaxis, we will follow the RCOG guideline, and chronic spinal cord injury will be considered as a +1 risk factor, okay, additional factor. Then respiratory care, lesion above the level of the T4, ventilator compromise assessment is required. Assess vital capacity. If it is less than 12 to 15 ml per kg, ventilation will be required. Bladder and bowel, intermittent or indwelling catheter that will prevent retention, and that can be autonomic dysreflexia trigger also. For bowel, prevent constipation, give high fiber diet, laxatives, timed evacuation, etc. Spasticity is increased in pregnancy around 12%. Then treatment is baclofen, which is preferred intrathecally, or oxybutynin for bladder spasms. Okay. For labor and delivery, uterine contractions, they travel via Frankenhauser's plexus. So via T10 they will be traveling. Cervical dilatation, the pain travels via T11 to T12, and perineum and vagina, these are the lumbosacral routes, ST to S4, they are responsible. Okay, so the transmission of the pain is from different ways. For uterine contraction, via Frankenhauser's plexus, they travel via T10. For cervical dilatation, it is the pain will travel via T11 and T12. For perineum and vagina, lumbosacral routes S2 to S4 are involved. So key correlation is that, that if the lesion is above the level of the T10, there will be painful labor. Sorry, if the lesion is below the T10, there will be painful labor, normal perception. But if the lesion is above the T10 level, the pain will not be felt. Okay. So below T10, normal pain. Above T10, there will be no pain. The chances of AD, spasms, and palpation is required. Okay. There are chances of autonomic dysreflexia and spasm. Then recognition of the labor. If the lesion is above the level of the T10, labor often not perceived. So alternative signs of autonomic dysreflexia, scalp tingling, increased spasms, abdominal self palpation, that we need to rely on. Okay. So antenatal planning of the labor, consider hospital admission around 36.6 weeks of gestation, daily CTG, 4-hourly uterine activity monitoring will be required. Alternatively, home uterine monitoring can also be advised. Patient education, recognition the non-pain labor signs. So patient should be taught regarding the labor pains also. Okay, when they do not feel or perceive the labor pains, what are the other signs of the labor? Okay, then first stage of labor, early admission is required. MDT care will involve obstetrician, anesthetist, trained nurses. Analgesia, early epidural, if the lesion is above the level of the T6, that will prevent autonomic dysreflexia. Bladder care, indwelling catheter will prevent bladder distillation, and that is one of the factors for AD. Then procedure like vaginal examination, catheterization, it should be very gentle, and topical anesthetics, this use is required. That will prevent the AD and spasms. Continuous CTG monitoring is required to detect the fetal distress from the autonomic dysreflexia. Nursing care to prevent the pressure sores and manage spasms and AD. In the second stage of labor, spasm may be complicating the delivery. So manage with optimal positioning. Avoid forced flexion. If AD is uncontrolled, instrumental delivery can be performed either by forceps or ventus to shorten the labor. Before instrumental delivery, ensure adequate analgesia and may require spinal anesthesia also. Okay. In the third stage of labor, it is the standard management. Then ergometry, if there is no AD, then it is safe. If there is a history of autonomic dysreflexia, avoid. Okay, avoid during active episode. There is a limited data, so better to be cautious. Then coming to the cesarean section, only for obstetric indication. Cesarean, it is not a direct indication for cesarean section. So cesarean section is reserved only for obstetric indications. The rates are higher if the lesion is above the level of the T5, that is 1 in 2, almost around 47% chance of cesarean section. They are, and it is lower if the lesion is below the level of the T5, that is 25%, that is 1 in 4. Okay. Surgical consideration, LSCS with suprapubic. Sometimes these patients have suprapubic catheter also. So along with that also you can perform the cesarean section. Okay, it is safe. Their post-operative care, specialist nursing, turn patients every 2 hours, prevent pressure sores, early gentle physiotherapy is required. Suture removal, generally by daytime it can be performed, and these patients will require a thromboprophylaxis. Then coming to the episiotomy and perineal care, suturing, even if these patients do not have pain, still you require analgesia for these patients, because if pain is not perceived, uh, uh, still there are chances of autonomic dysreflexia and spasm. So still you need an analgesia to prevent the AD and the spasm. So there is no specific as such indication for the specific suture material. The routine can be used. Then postnatal care, analgesia is same as general population, and it helps to prevent the AD and the spasm. Okay. So this is the anesthetic review. So medical history and examination is to be done. In respiratory, date and time of respiratory tract infection, ITU admission, history of tracheostomy, vital capacity assessment in lesions above C7, cardiovascular autonomic dysreflexia, musculoskeletal, we need to note down the spasms, contraction, pressure, etc. Surgery, spinal surgery, history of spinal surgery, etc. These are the factors which we need to note down. Drug history like baclofen, anticoagulants, etc. are important from anesthesia point of view. And examination investigations, full blood count, renal and liver function test, and most important, vital capacity in lesions above the level of the C7. Okay. So lesion above the level of the T6, early epidural. If the epidural is failed, then continuous spinal anesthesia can be given after senior's review, and GA if the patient is high risk. Okay. But keep in mind that it will be difficult intubation. Goal is to prevent autonomic dysreflexia. Postnatally, pressure sore prevention, thromboprophylaxis, and physiotherapy. Breastfeeding is usually normal. Above the level of the T4, there may be delay in initiation of the breastfeeding, and baclofen can be given in the postpartum period. Contraception, oral contraceptive pills, they are to be avoided because it increases the thrombosis risk. IUCD may trigger autonomic dysreflexia, and POP and implant they are preferred. Okay, so from FSRH point of view also you remember POP and implant they are preferred, not the IUCD and the COCP. Okay, so during pregnancy there is a increased miscarriage, anomalies due to hypoxia, there can be early injury. Then management, maternal resuscitation is important. Supine hypotension, avoid supine hypotension, and strong thromboprophylaxis is required. Anesthesia notes, avoid suxamethonium 3 days to 9 months post injury. Okay. What can be used is a rocuronium that can be used. So take home message is that lesion above the level of the T6, there is a risk of autonomic dysreflexia. Lesion above T10, no labor pain. Early epidural will prevent prevention of AD. Bladder distension, that is the most common trigger for AD. Blood pressure rise more than 20 millimeters of mercury above the baseline is a sign of AD. Vaginal delivery is preferred. SCI does not increase congenital anomalies. Suxamethonium is contraindicated in recent SCI. Early epidural is important for prevention of AD. CS is only for obstetric indication. Instrumental delivery is preferred if AD in second stage, and analgesia is needed if the patient doesn't feel pain. So even if the patient does not have pain, still you need to give AD. Okay. Doctor, we have a few questions. Can you please read the questions and
Yes, sir.
attempt?
Yes, sir. A pregnant woman with spinal cord injury at T4 develops sudden headache, sweating, and BP 150/90 mmHg. Diagnosis: A. Preeclampsia, B. Autonomic dysreflexia, C. Sepsis, D. Anxiety, E. Migraine. So it is B. Autonomic dysreflexia
Yes.
above T at
Yeah.
T4.
Next.
Most common trigger of autonomic dysreflexia in labor: A. Pain, B. Bladder distension, C. Uterine contractions, D. Vaginal examination. E. Anxiety. It is B. Bladder distension.
Correct. So B, bladder distension. Next.
Best preventive measure for autonomic dysreflexia in labor. A. Opioids. B. Early epidural. C. Sedation. D. Elective C-section. E. Oxygen. This B. Early epidural.
Correct. Very good.
A
Next.
woman with lesion above T10 will feel labor pain normally, not feel contraction, have increased by, have no fetal movement, always need C-section. She'll not feel contraction.
Yes, about the T10. But PT movements will also be
That
hampered
given
actually.
altered fetal movements
Yeah.
like that.
B is the given answer. Next.
Which drug is the first line for acute AD? A. Methyl dopa, B. Nifedipine, C. Atenolol, D. Magnesium sulfate, E. Hydrocortisone, B. Nifedipine.
Yes. Very good. Next.
Mode of delivery in spinal cord injury, always C-section, always instrumental, vaginal preferred, elective C-section at 37, depends only on patient's choice. C vaginal is preferred otherwise.
Yes. Vaginal is preferred.
Which level of injury is highest risk for autonomic dysreflexia? Below T12, T10, T8, above T6, lumbar. It is above T6.
Yes. D.
Which is true about BP in spinal cord injury? Always hypertensive, baseline BP is low, no change in BP, always tachycardia, autonomic dysreflexia causes hypertension. It is B, baseline BP is low.
Yes. Baseline BP is low. Next.
Contraindicated muscle relaxant in recent spinal cord injury. A. Rocuronium, atropurinium, hexamethonium, becuronium, pancuronium. It is C. Hexamethonium.
Yes. Hexamethasone is contraindicated. Next.
Breastfeeding in spinal cord injury: A. Not possible. B. Contraindicated. C. Delayed initiation in high lesions. D. Causes AD commonly. E. Requires formula feeding. It is C. Delayed
Yes.
initiation.
Delayed initiation.
Delayed initiation in high lesions.
Yes. So that finishes today's topic of spinal cord injuries in pregnancy. Thank you.